Hi, everybody. This is Erica Mello and Susan Clinton, and welcome to episode number 167. And this is a patient of mine who I treated in the past who had suffered a compression fracture. So Susan and I talk about at what point do you stop treating the actual fracture, because it wasn't his pain generator at that time. And at what point do you start looking at movement patterns? And this sort of shows you the beauty of thinking out of the box and looking at other areas, which is the hallmark of our podcast. So hope you enjoy it. And for our new listeners, thank you so much for listening. And if you haven't left us a review on wherever you listen to podcasts, we would really appreciate it. It helps the algorithm find us and bumps us up in the rankings. And our website, toughtotreat.com, is there. And if anybody has any questions on a specific region of the body, type that into the search bar, and all the episodes that we've discussed with that word in it will come up. And for those of you who haven't opted into our newsletter, we have one that comes out every week discussing the podcast. And we also have a Clinical Pearls PDF that I've written and a sleep and persistent pain that Susan has written. So you'll get those PDFs once you opt in. Enjoy the episode. Hi, everybody. This is Erica Mello, along with my wonderful co-host, Susan Clinton, and this is episode number 167. How are you, Susan?
Good. Moving deep into the summer.
I know, my God. June, thank God, has flown by. I'll be happy when this month is over. Moving into July 4th. I get very patriotic around July 4th for some reason. I end up watching all these old, I remember John Adams on HBO. That was so good. I ended up watching that over and over again on July 4th. Crazy. Anyway, let's get to the patient.
Yeah.
This is one of my patients. And as I said in the intro, I'm at a point now where I want some input. So I will fast forward, okay, because he's doing a lot better. He is about 26 years old, male. He suffered a seizure at the end of November of 2022. No falls, nothing. It was just like, this is what I got. Scans were negative, and he suffered and he also got a compression fracture after that. I was like, how can you get a compression fracture after a seizure? I do not know, but he did. It was either coincidental because there was no trauma involved, or so he tells me. He may have fallen or something and not remembered it when he had a seizure. I do not know. Okay. But his scans and everything were negative. He did have an x-ray along with an MRI of his low back and his thoracic spine. Actually, his compression fractures at T6. And that's exactly where his symptoms are. Okay. So he came in complaining of pressure and pain bilaterally, right and left around the T6 vertebrae. And he also had some issues with his right external oblique. Probably, sits a lot, has a standing desk, was seen by another therapist overseas who I know, who referred him to me. The main issues at the beginning were, he basically had, in terms of past movement and medical history, besides we have bilateral ankle sprains and a right ankle fracture. Okay, so that always raises my radar. He's a big tennis player. Other than that, no major issues. He had some issues with rotation, thoracic seated rotation. He told me when he was seeing the other therapist. So that's his medical history. No one knows why he had the seizure. His scans were negative, CT, the head, everything negative. They did all these panels on him, nothing. So he's been fine since. So when I first saw him, he was explaining to me that he really couldn't turn his trunk to the right, and he was constantly gripping. Like, you could see him stand up. And when people try to stand up and they try to give themselves really good posture, they sit and they brace their scapula and they retract. And that's what he did constantly. And he also, I noticed, held his breath a lot for some reason. Like, if I put my hands on him, the breath would go. And I think he's a lot better with that now. So do you have any questions so far, Susan, or should I just keep going?
No, I don't have any questions other than, is he on seizure medication now? Has he had a seizure since?
No.
Okay. I'm just wondering, if it's very unusual to just have one like that. It must have been
I know.
It must have been a very hard seizure for him to have fractured his T6 vertebrae.
Without physical trauma,
Yeah, well, when seizures can be pretty violent.
Yeah.
So, just
Yeah. No, I know.
pretty, it's very rare for sure. Young
Yeah.
guy.
Yeah.
Yeah.
Young guy. Exactly. So, for me, I'm just looking at pictures of him here. His center of mass actually was fairly okay. Okay. He was a bit off to the left. In standing, he basically said he had problems with prolonged positioning. So prolonged standing and prolonged sitting. And he sat a lot at work, very high stress job here in New York, sat a lot, but he did go to stand quite a bit. Okay. Because of that. And so I just had him squat. I looked at him squat. He went way to the left. Not surprising because he had a right ankle fracture, probably some years ago, and he just adapted to it. And so I said, when you stand, do you notice if you're standing on your left leg? He's like, I probably do. I'm like, okay. So that was just another thing in my brain. The compression fracture has healed, quote unquote, right? Has healed, but he was still complaining about, like, when I saw him 2 months after, maybe 3 months after the fracture, or who knows if he had the compression fracture after the seizure, because he'd never had anything imaged before, but it was an acute fracture. So they think it was probably because of the seizure. So I saw him like 2 to 3 months post. He said it had healed. And I was like, well, it may have, but ultimately you're going to adapt to it. So I want to get fast forward to now. Okay. So in standing, he was very centered, except he was a little bit biased to the left side. When he squatted, he went way to the left. I was more concerned with because in standing, he just stood there with a really rigid back, complete retraction, dumb scapula, T-spine extension. I said, can you bend forward for me? And he's like, like a rod right down, had no of that sort of posterior translation of the thorax. I had him sit and I said, can you slump? And he was like, and he really couldn't, he didn't have any mobility through there, through the T-spine. And then I had him turn to seated trunk rotation, hands across his chest. He rotated to the left fairly okay, like 50%, 60%, not horribly. But then when he went to his right, he would dump that right shoulder blade down and he would reproduce his symptoms at that level. His symptom was at that level. So I was explaining to him, I was like, your pain generator is definitely your fracture site. I mean, that's your generator. And that's where he was feeling his symptoms. And to this day, he's significantly better. He still gets symptoms there.
I'm sure it's nice after all this time and after what happened.
Exactly. So the main thing that I found from a sort of alignment, quote unquote, perspective was he had a lot of translations in his rib cage to the left, mostly ring 7, which was just below the T6 vertebral complex. So relevant, I think so. That's, and then he also had quite a rigid right foot. Okay. So those are the main things that I saw. So I'm going to really go quickly with this because I want some input. So I ended up having him go normal, narrow, wide, and standing, not surprising wide. He, lined up much better, quote unquote, in his thorax. When he went narrow, he offloaded that right foot. Is that an issue for standing? I absolutely think so, because that's his issue, and so, but it didn't 100% make the thorax stacked up, so to speak. So I ended up manually correcting his foot and then feeling up his rib cage. And once again, he stacked up nicely, but he still was offloaded to the left. So I treated both. I treated both. Okay. So I'm going to go fast forward. I treated both the foot because it really helped his center of mass and his trunk. I treated his scapular bracing. He felt that his back was very stiff. I told him he could lie on the foam roller if he wanted to. I don't usually give that out a ton, but that helped him a lot. I had him go vertical on the foam roller and do a lot of scap retraction. I had him in the Pilates facility doing some roll downs. I had him do on the Cadillac. I had him go on all fours because the breath holding was concerning. He's constantly holding his breath. And I was like, what the heck? I had him on all fours, have him drop his belly and do a lot of just belly breathing and diaphragmatic breathing. Lateral costal breathing. That helped a lot for him. And then I ended up having him go just basically a thoracic progression, like you've heard us talk about multiple times. I had him do some wall squats. I had him go lie on his back with a So supine and just have him reach for the ceiling like he's retracting his scapula bilaterally, and then have him do TheraBand around the forearms, skull crushers, chest press and overhead flexion. All fine, all good. Okay, that got him to where he is. And I can, if anybody has any questions on that progression, I'm happy to talk about, but I wanted to talk where we are today. So he's progressed through a thoracic progression in terms of, scap protraction, squatting. I've had him lunging with the foot. I did some release on his foot. I treated his foot. I had him do some split squats, sling squats, things on the Pilates reformer. The best exercise for him was a split squat with the involved side back and a bit of plantar flexion and alternating tricep extensions. That really got the rotation. His trunk rotation is significantly better. However, with prolonged positioning, he still sometimes gets these symptoms. And my question is that like he can rotate fairly well now. Everything objectively is good, but he still does this thing where he has to he grabs his scapula. It's like almost like a habit, right? He grips it and I told him to stop doing that, basically take out a picture of Shirley's Armin's, but just don't do that anymore. He stopped that 50%. He said it's helped, but I'm wondering, and I can, answer any questions you have, if there's something else that I need to do to clean this last piece up. So I've done a lot with, in thoracic posterior translation, I've done with balls, I've done, I've treated the foot. The foot absolutely helps. 100% has helped. It's mostly sitting. So the standing has helped quite a bit. The foot, he still is a bit rigid. But I'm okay with the foot. I'm okay with that. He still has this translation into the left. When I go in and I palpate, iliocostalus and serratus on that side, he's quite sore and tender. And he's like, do you think it's still coming from the fracture? I was like, it's a tough one, I was like, well, not exactly. It's your compensations around that. What do you think?
So which side is the serratus and the stuff tied on when he
left serratus and bilateral
left? Yeah. Okay. So in sitting, what does he look like?
You mean in terms of thorax or just he's pretty rigid.
It's been rigid in extension, rigid in flexion, rigid.
I'm sorry, rigid in extension. It's rigid. No, he can slump a little bit. But he's rigid. Like he'll brace his scapula, and then to get him to sort of slump, I'll have to literally cue him to go, head, to do to posteriorly translate the thorax.
Yeah. So I think it's probably a learned thing, because in the beginning, it took everything he had to say, because fractures do not like compression or traction.
No.
So he moved himself into a pretty rigid extension to get off of the fracture.
Right.
And I imagine that there's probably some sensitization around, around that area, when he stays there too long, the alarm bells go off in the head, and then it's like really hard to get out of that position.
Yeah.
So he may have, I don't know what his x-rays or anything looks like, but he may have a bit of. So what happens with that compression fractures, it doesn't always come back up to like a full, nice looking vertebral body. It's probably more than likely what has happened is it's probably either it has wedged, but it's not even. And so what's happening, and I'm wondering if there's actually a lip that's formed on there, so that when he goes into extension, he's actually formed a lip, and he can't get out of extension at that segment.
Exactly.
Yeah. So flexion can help a little bit, but what he needs is traction.
Yes.
And I'm wondering how he can suspend himself, and let go. I don't know that, him pushing down with his arms onto something to like have his trunk, kind of just wiggle off of that would work. I don't know if he can do it with his elbows onto something, and like, can he let himself go enough to where he can actually get traction in that area? I love him laying on the foam roller or on just even a towel. And I would even think that he could roll up a towel and put it under T7. So that he can get a little bit of, traction and extension at the T6, T7 level. You can try, a nice towel rolled up that way and figure out where it feels the best to kind of relieve the symptoms at that segment.
Yes.
That segment. But Yeah, that I'm, putting things underneath his arms isn't going to be good to have him traction off of, because you're
No,
just going to compress the brachial plexus and give him, numb hands.
right.
Trying to figure out what he can do. I don't know. It might even work to have him put him, just is there anybody around who has the weighted vest? I mean, not weighted, the unweighting vest for the treadmill. Something
No.
like a vest that he can unweight with, that you can put on and literally hang from, or we'll just pull
Yes, 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 yes.
I'm
Yes.
just thinking, how could he get, maybe for him, maybe he needs to do some inversions, like downward dog, or he can even like
Yes.
for traction,
So,
he could just like get on a box, like at the gym, the
yep.
top boxes, and he can just lean, at his hips over and really suspend himself down. He would probably need to have somebody hold his
Hold
legs,
his feet.
or something. But there's got to be some ways to get him to go into some traction. I would think inversion might feel more comfortable to him than trying
Yes.
to hang himself, by
Yeah.
a vest or something. And certainly the only reason I hesitate about his arms is because he tends to like overcook and work those scapular muscles so much.
He does. I have him doing like just kneeling on the wall and doing like a kneeling sort of squat. I had him do the down dog, but I know he's not been compliant with that. The foam roller has helped him the most. He told me that is what's helped him the most.
Yeah. What
And
about can he do, instead of a doorknob squat, can he hold on to pulleys and go down and do a squat that way, like a
yes,
TRX?
yes, we have that in the
Can
gym.
he?
Yes,
Yeah, if he could pull, grab hold of the TRX and go down,
yes,
and and allow himself to stretch that way. Something
yes,
dangling from his. He could tie one of those. He could put a what do you call the bars that go on the door to do press ups?
yes, yes, yes,
He
yes,
could actually put one of those big elastic bands and put it around, do a slip knot around the bar, and he could literally get in that and just like twirl his arms up in it and just allow himself to go all the way down and really get that nice
yes,
traction lengthening for him that he could do just right there,
yes.
so he doesn't have to wait to get to a gym or somebody to do it.
Yeah, even at his desk, I'm just wondering if he can just hold on to the desk and just squat down with his hands, because standing's a lot better. But I like those ideas. I think for him, I'm just thinking, because he was explaining to me, he's like, why does my left side hurt? I said, you just that's been there. That was there before you had the seizure. Okay. It's just, unfortunately, it became an issue, but that's not the issue.
Protective response. Yeah.
Exactly. And so I've given him, it's interesting. I'm taking, as I mentioned earlier, off air, I'm taking this imaging course for my doctorate. And as you're describing the compression fractures, I'm seeing the lipping on the images that we're looking at. Right. And it's just, I think I think physical therapists should learn how to read x-rays. And I think that if you haven't taken an imaging course, I think you should, because Susan and I both have taken it. So I think it's important, as I'm visualizing this in my brain and going, of course, it makes complete sense. He needs traction, right? And these are all great ideas. I'm wondering, down dog, because the rotation, everything is a lot better.
You know what he could do rather than down dog is he could lay on a Swiss ball.
Yeah.
And invert and put his hands down to the floor, but the ball could literally hold his lower body up.
Yes.
And it would take him into traction and probably a little bit of flexion.
Yes.
So it might help him, just unhinge or just get enough exposure to that area to where it could settle down around it.
Yes. That's a great idea. I mean, even when I have him on the reformer in the knee stretch position in like a neutral and I have him push back, he's still getting a little bit, but it's, 8 reps, less than 2 minutes. It's not enough. It's not enough. So those are great ideas. I think that's all he really needs, to be honest, at this point. He's that, I wanted to bring him up because he's made so much good progress, but he is still complaining about a little bit with sustained positioning. So I think you're right. It's just lost its ability to, what's the word I'm looking for? Its ability to sustain the load or the compression, I guess,
Yeah.
with the
Yeah.
fracture, right? So
Well, and it's probably changed structure. So
yes,
when he
yes,
loads now, it's different, and his brain is interpreting that as that's a problem.
yes, yes.
And and it's probably, and again, bone and pericardium is sensitive as hell. And it just maybe has gotten sensitized now at this point. But anything he can do to unweight that, I would think, is the best possible place to go, because sitting in that extended posture there's a lot of compression there.
Yes, and
Sitting
even in
flat, there's a lot of compression there.
exactly.
So it sounds to me like what he really needs is the traction component, or the unweighting component, if you will.
Yes, yes. We have the almost like a TRX in the Pilates place I'm in. I will definitely do that. And one more thing.
Yeah, play around with that. Play around with the big band and see if he can like literally wrap his arms in it like once or twice, so that he doesn't have to hold on with his fist so hard, and just see if he can just let himself down, like to where almost like headed towards a squat, or just even sitting, but all of that's pulling up, and his whole thorax is lifting, and getting enough unweighting through there. Might be able to help him. He could even, I'm just even picturing, if you could get it short enough, he could wrap it around his back, the band underneath the, below the T6 region, or just like right at that T6 region, or maybe just right above. You have to play with it and see which gives him the best. And have him and then hold on to the wrist with his arms up above, because the band's coming around his back. And see where he can get where it feels the best, because that's something he could do at home.
Yes. That's a great idea. And I'm going to see if I can get a hold of the X-rays. They were done in the overseas, so I'm not sure.
It'd be interesting to see what they look like now.
Yes. I've been on him to send this stuff to me. So, but I do think it's important to think about that compression and the wedging and the lipping. It's very true. And I think that's the issue. So, all good. This was a good one. We talk a lot about patients, obviously here, but this guy is, we all get them to a point, and then you're like, just something, there's something. And we do have to go back to the pathology at some point, especially when somebody comes in like this, right? So awesome. Well, thank you, Susan.
You're welcome. Thanks, everybody. Thanks for listening. As always, please leave us a review so that everybody can find us. We appreciate it, and we look forward to any questions or comments you may have. Thank you.
Bye.